guys, today we are going to discuss about hepatocellular carcinoma. Etiology: 5.4% of cancers worldwide. Geographic areas with high risks of hepatitis B are prone to get hepatocellular carcinoma. Incidence: young adults between 20 to 40 years. Maternal to fetal transmission is there. Male predominance is there, 8:1. Coming to pathogenesis: chronic liver disease associated with the cirrhotic patients are prone to get hepatocellular carcinoma. 15 to 20% of non-cirrhotic patients with underlying diseases like chronic viral hepatitis B and C, metabolic diseases such as hemochromatosis and alpha-1 antitrypsin deficiency, and acute liver disease and alcoholic liver disease. Non-alcoholic liver disease without cirrhosis patients are high risks to get HCC. Chronic injury, inflammation and hepatocyte regeneration are driver mutations for HCC development. In Africa, Asia, aspergillus, due to the overgrowth of aspergillus fungus, there is a production of alpha-toxin and mycotoxin by aspergillus, which will increase the chance of getting hepatocellular carcinoma associated with along with hepatitis B and alcohol. Okay, risk of hepatocellular carcinoma in cirrhosis, Wilson's disease and chronic biliary disease are more. So most common are activating mutations in beta-catenin gene. So in 40% of tumors, we saw this beta-catenin gene in APC, and in colorectal carcinoma, and mutations in even in gastric carcinoma we saw this beta-catenin gene, and third gene we saw in melanoma, so which upregulate the telomerase activity. So inactivating mutations in TP53, which is most common in almost all tumors, like even in case of HCC. Okay, fibrolaminar HCC, there is a fusion gene, apparent activity of phosphokinase A, which leads to cyclic AMP pathway and increased cellular proliferation. Okay, so coming to morphology. Non-cirrhotic liver, HCC arises in hepatic adenomas. Okay, some benign tumors which may further leads to HCC, and especially in those with beta-catenin activating mutation patients, they are more prone to get HCC. In chronic liver disease, earliest morphological correlates with the presence of at-risk hepatocytes. At-risk hepatocytes means they have large cell change and small cell change. What is large cell change? Here, as the name suggests, large hepatocytes are larger than normal. Okay, and large multiple pleomorphic nuclei will be there without increase in the nuclear by cytosolic ratio. In small cell change, what will happen? Hepatocytes have a higher N by C ratio. Okay, mild nuclear hyperchromasia or pleomorphism, and more ominous in cirrhotic livers, which further leads to dysplastic nodules, which are associated with small cell change. Okay, in large cell change we won't see any difference in nuclear by cytosolic, whereas in small cell change we will see that. And in every cancer situations we will see hyperchromatism and pleomorphism. Okay, dysplastic nodules, they differ from adjacent cirrhotic nodules in size, color, vascularization. They show various degree of dysplasia, clonal aberrations, which further leads to full-blown HCC. In small areas of HCC, there is a high grade dysplastic nodules, which will be seen as nodule-in-nodule appearance. HCC may form a single mass or multiple discrete masses. It may diffusely infiltrate the liver. Okay, pale and yellow due to fatty changes, or green due to cholestasis. Okay, due to cholestasis it may appear green color. If there is any cholesterol deposition, it will appear as yellow color. Tumors greater than 2 centimeters along with vascular invasion and intrahepatic metastasis. Invasion of veins along with the extension into the portal vein. So portal vein joins into IVC. So IVC will go into right atria. So there is a right right heart of the right side of the heart involvement also may occur. Okay. So coming to microscopic features, well and moderated differentiated hepatocellular carcinomas are composed of cells which resemble normal hepatocytes. Poorly differentiated tumors, they have marked cytological atypia. Okay, means increased N by C ratio. Tumor cells, they grow in the thick plates or trabeculae, pseudogranular structures with bile plugs or sheets. Distinctive fibrolaminar variant, it has triad of features. The triad of features are large polyclonal cells with granular cytosol. Abundant mitochondria are seen. Lamellae of dense collagenous bundles and vesicular nuclei with abundant nucleoli. Coming to clinical features, most of the symptoms are non-specific. Patient may be presented with abdominal pain, malaise, fatigue, weight loss, and hepatomegaly, and chronic liver disease features. Elevated levels of serum alpha fetoprotein, which is not associated with the fibrolaminar variant. In ultrasonography, okay, we will find this cirrhosis, and CT, MRI, these are the findings. Okay. We will see some changes in the liver in these. So early enhancement of tumor due to contrast uptake in the arterial phase, which is followed by rapid venous venous washout, okay, which is diagnosis of HCC. Treatment is surgical resection. In chronic cases, liver transplantation is also suggested. Okay, image guided tumor ablation with alcohol or radio frequency waves done for unresectable tumors or those that do not meet the criteria for transplantation. Hematogenous metastasis to lung in late stage of disease. Lymph node metastasis in less than 5% of cases. Outcomes of HCC are poor because due to the underlying liver disease and intrinsic resistance of HCC for conventional chemotherapy. 5-year survival rate in 30% of tumor confined to liver. 5 to 10% of cases, they have extra hepatic spread. Outcomes better in fibrolaminar variant. 40% of patients survival rate is 10 years survival or longer. Absence of underlying liver disease. So surgical resection is very easy in that.